Hello everyone, good evening, and welcome back to another edition of our webinar series. My name is Anushka, and I'm the Scientific Development and Communications Officer at the Center for Brain and Mind NIMHANS. We're really happy to have you all here with us today. Today we'll be having a talk by Professor Sagnik Bhattacharyya, and I would like to hand it over to Dr. Venkat for a short introduction, after which we will begin. The talk will be for 45 minutes, followed by 15 minutes of question and answers. I request all the participants to please keep yourselves muted. And if you have any questions or comments, you can leave them in the chat box, and we will go through all of them once the talk is over. So, Dr. Venkat, please go ahead.
Thanks, Anushka. And thank you, Professor Sagnik Bhattacharya, for accepting our invitation and giving your valuable time to enlighten us on a very important topic, that is imaging cognition to investigate psychosis. Professor Sagnik Bhattacharya is a professor, and he heads the Translational Neuroscience and Psychiatry Research Group at King's College London, where his work delves into the complex interplay between the neurobiology, psychosis, and substance abuse, with a specific focus on cannabis. So his work has been pioneering, including several inspirational work that he has done here at NIMHANS, where I have learned a lot through several interactions with him, and he continued to pursue the path of cutting-edge research work and has conducted wide-ranging research that can encompass us at one level from clinical trials to examine the efficacy of cannabidiol in conditions like psychosis and Parkinson's disease psychosis, as well as he nicely blended several experimental medicine approaches that integrate neuroimaging techniques and pharmacological challenges. So his efforts have shed light on the distinct neurophysiological effects of various cannabinoids, providing crucial insights into their therapeutic potential, especially the potential of cannabidiol as an antipsychotic agent. The translational impact is already visible thanks to his pioneering work, where we have the cannabidiol now available in several countries, including India. So in today's talk, he will briefly recapitulate the general approaches and principles in relation to functional neuroimaging in psychosis, and focus on some example application, and then move on to limitations of current approaches and future directions. So thanks again, Professor Sagnik, and we look forward to learning from you.
Many thanks, Venkat. It's a real pleasure to be here to give a talk once again at an institute which I have very fond memories of. So it's now a little over 2 decades back that I spent great 6 years, very formative years of my career. Professor Reddy is here. He was one of my supervisors for my DNB dissertation, and of course supervised many of my clinical placements. So thank you very much for the invite to Venkat, Professor Reddy, and the team. And Venkat also was one of my contemporaries, so our paths crossed, and Venkat was also my supervisor during my MD training. So thank you, Venkat. It's real pleasure, and thank you for the very kind introduction. I'm not sure that all of those are necessarily true. So whoever listening, please take it with a pinch of salt. But I'm not really going to focus a great deal about my own research. I'll definitely talk a little bit about my research, but it is more, I understand that a lot of the attendees will be also students at various stages of their career. So so this is, as Venkat said, that I'm going to focus really on, let me see if I can manage. And this is just a disclaimer, so that none of what I'm going to talk about represent the views of my employer or my funders. But this is what I'm going to focus on. So really first of all, briefly touch upon why should we focus on cognition to investigate psychosis. We'll try to recapitulate some of the general principles of imaging cognition with the specifically then moving on to some examples in the context of psychosis. The purpose of this is really to remind us how it all started and what are the underlying principles. And of course, these underlying principles also mean that there are, although we have some very shiny tools and great images to show, but they are by their very nature, there are some limitations to these approaches. So we would then move on to some of the limitations of current approaches, future, and then focus on some future directions. The purpose is really to give a sense that, yes, these are great tools. They provide great insight. They have use. They have advanced our knowledge, but they also have limitations. And so when we look at the insights that these tools have helped generate, we will be mindful. If we are mindful of those limitations, then we will not overreach in terms of inferring from the results of what we do. Okay, so first of all, why should we focus on cognition to investigate psychosis? Really, this doesn't need much explanation or reasoning, but we know that cognitive dysfunction is not limited to just psychosis, but it happens across a range of psychiatric disorders. And although we most often talk about the symptoms and signs of the different disorders that we deal with on a day-to-day basis, and we seldom talk in the same breadth about cognitive dysfunction, but cognitive dysfunction is a particularly important aspect. And that's because cognitive dysfunction is associated with disability. They result in impaired functioning in various domains, social, occupational, and relationships, associated with poor remission and long-term recovery. Of course, poor quality of life, and often they are associated with poor response to treatment and poor adherence to current treatments. Hence, there is a particular need to understand their neural underpinnings better. But that's just one reason why we should try to understand cognitive dysfunction in psychiatric disorders and specifically in psychosis, but that's not the whole reason. But before we think of why else we should focus on cognitive dysfunction in psychosis, what do we know already about it? Can you all hear me? Sorry, I should have checked this earlier, but because I can hear some, yeah, okay.
Yes.
Yeah, so I thought that this is a very useful review. It's now more than a decade old, which really is not specifically about psychosis, but it talks about cognitive dysfunction across various neuropsychiatric conditions. And all it essentially suggests is that cognitive impairment is common across different diagnostic categories, as you can see here. And there are certain universal domains that seem to be affected across most diagnostic categories. And these are listed on the left. Means I'm not kind of suggesting that you should really focus on each of those domains at this point of time, but this is just to kind of really give context to what we are going to talk about in a moment. And of course, those are, then there are also some higher domains which are affected in a more disorder-specific way, such as those on the right, like episodic memory, social cognition, etc. And kind of underpinning all this, we know that there are both molecular, neurochemical, as well as other abnormalities that underpin all of these cognitive domains affected. and not just at the molecular and neurochemical, neurotransmitter level, but there are perturbations, both physiological perturbations at multiple scales that can be measured, for example, by neuroimaging techniques that underpin these cognitive dysfunctions. And they are a result of multiple different factors, say, whether it is genetic, environmental, developmental, all of those risk factors combine to cause some of those underlying molecular dysfunctions, as well as more systems level physiological dysfunctions, which can get manifested as some of these cognitive domains that may be impaired in different psychiatric disorders. And these all happen at multiple scales, both in terms of spatial scales, so such as abnormalities that affect molecules, to more larger scale abnormalities affecting cerebral circuits, and as well as at multiple time scales. So not just multiple spatial scales, but also multiple time scales. Certain dysfunctions are evident in the course of milliseconds. So for example, perturbation of kind of gamma on theta oscillations, and some dysfunctions get manifested over the time scale of years. So this is really a useful way to think about cognition in the context of psychiatric disorders in general, as a useful framework. But moving more specifically to the different disorders, and although we are going to focus today mainly on psychosis, as you can see, if you have a closer look at the top part of this panel, that it shows that a range of different cognitive domains are affected, and they are not really very, they are fairly agnostic, disease agnostic, in the sense that they are affected. Many of those domains are affected across a range of disorders, as shown in the left column. And the number of pluses indicate the severity of the of the strength of the evidence, suggesting that kind of it's not that there is one unique cognitive domain that is affected in just one particular disorder, but they are generally affected to a kind of larger or a smaller extent across disorders, though there are certain domains such as working memory, executive function, or kind of episodic memory domains, which seem to be perhaps a bit more preferentially affected in psychotic disorders such as schizophrenia, a little less so in more affective psychotic disorders such as bipolar disorder. So the reason for pointing these out is that I will, in the examples that we're going to talk about, we will try to focus on some of these domains, because 45 minutes or even several hours is too short a time to summarize the entire breadth of evidence of what we know about cognitive dysfunction in psychosis. There are lots of studies, there are lots of kind of discrepant findings. So synthesizing all that is not something that I will endeavor to do. That's beyond my capability. So I'm just going to talk about just a few examples. These are neither exhaustive nor the most influential pieces of evidence, but these are evidences which I think will help demonstrate a few key messages, both in terms of the kind of the tools that we have, how they can be used, how they can inform us, but also helping demonstrate some of the limitations of those very tools, kind of for the audience today. So moving to the general principles, means this is nearly 1.5 decades ago that Ray Dolan, while reminiscing about his career, mentioned that neuroimaging gives us a physiological window into the human mind. So this is, his entire career has been built around, and his career started at the very time when neuroimaging techniques were just being developed, and he has played an instrumental role in current understanding about the neural underpinnings of various cognitive processes and how that helps in understanding cognitive dysfunction in various psychiatric disorders as well. So it's a really kind of useful thing to remind us of. And so earlier I told that we need to focus on cognition because it affects a number of different domains. It has effect on disability, quality of life, functioning. That's one way of conceptualizing the importance of cognition. But also another way of thinking about the motivation for focusing on cognition is that if one were to think that certain cognitive processes are impaired in a disease or condition, and perhaps are a core feature of that condition, then if we investigate their neurophysiological underpinnings, and in this context, we are thinking of neuroimaging as a tool to investigate their neurophysiological underpinnings, then that may give us a better idea about the pathophysiology of that condition. So the reason why we are investigating cognition using neuroimaging is also to get a better idea about what this condition is all about, what causes it. And by having a better idea about how the condition may arise through those particular cognitive domains being affected, that might also give us pointers towards what we might want to do to treat or prevent those conditions from emerging. So there is very real kind of important reason as to why we should kind of think of using neuroimaging to understand cognitive dysfunction in psychiatric disorders, more specifically for today, psychosis. So, and as a way of recapitulating kind of how it all started, they all started in the context of brain mapping approaches. So kind of this is more than nearly 3 decades ago now, when these techniques were used to try to understand the underpinnings of various neurological conditions, strokes, and other things. So they started off with lesion studies, trying to link various brain lesions with things like, say, speech abnormalities, etc. And at that point of time, it started off it all started looking at the brain as if it is a modular organ, that there are different modules serving different functions, and each have their own role, and together they all work very well, but each has a very well-defined role. So that's how it all started. And then the questions were, which brain regions have a role in which functions or processes? So it was still a very kind of looking at the brain as islands of kind of multiple islands that are all present in one large space, but all these islands have their own unique functions and roles in the bigger scheme of things, and they all live happily ever after. That's how it all started. And in the context of analyzing data using generated through neuroimaging approaches, most of them kind of used mass univariate approaches. So what we mean by that is the brain is a large 3-dimensional organ. And so one way of kind of organizing knowledge about it is to think of the brain as multiple volumes, to try to give a sense of where we locate certain abnormalities in space as well as also in time. And so each of these abnormalities would be tested, compared between different groups using what are known as mass univariate analysis approaches, which would mean running 50,000 to 350,000 different tests to create a whole brain activation map. So this is how it all started. And initially they started with PET studies, really using blood flow changes, looking at blood flow changes and metabolism changes with FDG, etc. And then moving on to mostly functional MRI studies And I'm going to today really talk about functional MRI study examples. And in functional MRI, we can measure a number of different things, but typically and most commonly, people measure what is known as the Bold signal in short, or the blood oxygen level dependent hemodynamic signal on the basis, and for those who are less familiar with this, kind of the assumption, and it is still an assumption, though there is some evidence in support, is that when there is an alteration in blood flow, that is really very tightly coupled to alteration in activity of the neurons in that region. And so by measuring the alteration in the blood flow through its proxy hemodynamic response signal, we can get a sense of what is the underlying alteration in neural activity. And so that's the underpinning principle for the majority of the neuroimaging analysis that we read about in papers. And that's what we are going to mainly focus on for today. Though I'm not going to get into the details of how this is generated, but it is more about that being a kind of a starting point for what we're going to talk about. And another way of kind of trying to conceptualize what we do typically in the context of using neuroimaging in conjunction with cognitive tasks is this is quite a nice way of showing that kind of conceptualization. So what happens in a typical neuroimaging experiment, whether it is in patients, healthy volunteers, or comparison of patients and healthy volunteers? This is often what happens. So there is an experimental manipulation. So we ask our participants to perform a cognitive task inside the scanner. And our assumption is that each of those cognitive tasks will really result in stimulation of or use of certain cognitive processes. Of course, we can't observe the cognitive processes themselves. We know that certain tasks are expected to kind of engage certain processes. So we is kind of with that assumption, then we try to interpret what we see in terms of the change in signal or fMRI activation that we see. So on that basis, we infer which cognitive processes are affected, how they are affected, and try to interpret the results of the fMRI activation on that basis. Now, one might do one task, one might do different tasks. And as you will see as we go along when we talk about limitations, there are certain assumptions in this that task one will activate cognitive process one, and that cognitive process one activation will engage process one, and that will result in a certain extent of activation that we measure on fMRI. But of course, there is not always just the one-to-one relationship in that one. Task two might also engage some of the same cognitive processes affected by engaged by task one. And so that creates some problems in interpretation or how we infer the results of infer on the basis of results of neuroimaging studies. And so we'll dwell on that a little bit as we go along. So what do we see when we do these studies? We see a difference in activation between patients and controls at the very simplest case. And then, of course, the question arises that are these necessary and sufficient brain systems? How do we interpret what differences do we the differences that we see? How do we know these are necessary and sufficient brain systems to explain the differences in cognitive processes between patients and controls? How do we know if there is dysfunction at a site distant to damage? Now, this question takes us back to the history of this approach, how it started, because it started as to understand brain lesions, strokes, etc., where the focus was not just on where the stroke was, but of course, when there is a stroke or when there is a tumor in a part of the brain, there may be mass effect, which might be quite distant from the site where there is the tumor. So, so the initial queries were, how do we identify whether there is on the basis of the changes that we see, whether the dysfunction is at the site of the damage or there is dysfunction at sites distant to the damage? How do we identify whether any change in activation is just around the damaged area or just in the damaged area? What do these changes mean? Are they a compensatory effect? Are they causal to what we see? So these are some of the questions I think worth keeping in mind, and these are some of the questions perhaps worth keeping in mind while interpreting or the results of the various neuroimaging studies that one may come across. So and again, this is work of Carl Friston, one of the pioneers of statistical parametric mapping software that was developed to analyze or make sense of the brain imaging data that comes from the scanners, and Kathy Price. This was in the very early days, as you can see, 1999. So to make sense of all the data that was coming out, they thought that this would be a useful way of trying to understand what it means. And I think, although this is quite old, this still serves as a very useful framework. Like if we see abnormal patterns of activation, that might mean two different things. It could mean compensatory changes in neuronal architecture, or it could mean compensatory changes in even cognitive architecture. And some of that neuronal architecture changes may be immediate pathophysiological reorganization, and some of them may be learning-related plasticity and reorganization. We often talk about learning, particularly in the context of learning and plasticity, particularly in the context of, I remember my training in child and adolescent psychiatry, where plasticity, reorganization, and all of those are things that we talk about a lot, and that's why we talk about how important it is to train, etc. But so you can understand that there are many different ways of many different changes that might lead to abnormal patterns of activation, and just by looking at something is more activated or less activated doesn't give us any sense of what is causing all that. And some of these changes might be local effect of lesion, they might be distant effects of lesion, they might be resulting in remote reduced activation or increased activation. So see, again, here at that point of time, it was all talk about lesions. Of course, psychiatric conditions, most of the psychiatric conditions do not have lesions per se, like we talk about stroke, we talk about stroke in a particular part of the brain. We don't have such a stroke in a certain part of the brain that causes schizophrenia or bipolar disorder. So it's not something that is as obvious. And so, although this is a useful way to think about things, of course, there are limitations of these approaches. So this is another way of kind of thinking about these things. Say, for example, when we see altered activation in neuroimaging data, that might mean there is decreased activation or there might be increased activation. Now, how do we interpret decreased activation? And this is where the task response, task performance is particularly important to interpret, to understand what it means. So perhaps there is normal task response, or there might be decreased activation may be associated with abnormal task response. And so if it is associated with normal task response, then one could reasonably infer that the region may not be necessary for the task. On the other hand, it becomes much more complicated if it is associated with abnormal task response. Does it mean that the decreased activation that we see is because of poor performance, or it's the decreased activation that in turn causes the poor performance. So what is the cause and what is the effect? So that's not as easily obvious when there is an abnormal task response associated with decreased activation. On the other hand, if you think of increased activation, that might be increased activation in regions that are normally engaged by that cognitive process, or it could be new regions that are not normally engaged by that cognitive process. If it is increased activation, then one could infer that it's a result of neural reorganization, or it could also be a result of cognitive reorganization. And what happens when there is neural reorganization? Patients are using the same set of cognitive operations as healthy controls. While if there is, and that essentially indicates there is this change in the strength of the pre-existing connections. That's what results in the increased activation. On the other hand, if there is cognitive reorganization, that might mean that there is greater cognitive demand. And to address that greater cognitive demand, there is greater cognitive reorganization, and that is what causes increased activation in the regions which are normally activated by that task. On the other hand, if there are new regions of activation, the interpretation of that is much more complex. Is it to do with changes in neuronal implementation, that is either learning-related changes in synaptic efficiency or a result of rapid reorganization following deafferentation? Or is it to do with changes in cognitive strategy? So as you can see that I don't have an answer, but to how one might interpret, it's not that anyone has an answer, but this is quite a useful framework to use while interpreting the results of what we see when you apply neuroimaging techniques to investigate cognitive function in people with psychosis. So it's the previous kind of what I was talking about is really to reinforce the point that functional neuroimaging findings, they really need to be considered in the light of performance in the cognitive task that was used in conjunction with neuroimaging to fully understand the meaning of those findings. So without that, without taking into account task performance information, we are really not in a position to understand what is happening actually in the brain that has caused those changes that we observe using neuroimaging. So with that, I'll move on. That's quite a bit of a preamble. So I'll now move on to perhaps something that will be a bit more interesting for many of you. But again, as I said, that it's too short time, nor do I have the expertise or knowledge to really give an exhaustive overview of the application of neuroimaging in psychotic disorder. So I'll just picked a few examples which I think will hopefully convey some something useful here. And for convenience, I have picked two examples which are my own work, so that I don't have to do as much work, try to understand what they have done. So that's a bit of my kind of, I'm raising my hands that please bear with my self-indulgence. So this first example that I picked up is, if you remember that when we were showing how the different domains are affected in different cognitive domains are affected in different psychiatric disorders, we focused on a few domains such as executive function, memory, etc. And the reason for focusing on executive function was because it seemed like, at least on the basis of the table that I had shown you a few slides back, that psychotic disorders such as schizophrenia have quite a lot of executive function impairments. So I thought that this example is a nice one from that perspective, that there is not much of a debate that there are executive function impairments in psychotic disorders. And so this study, what the authors have done, they have not, this is not just one single study where they image a group of people with schizophrenia and compare them with healthy controls. They took a meta-analytic approach. So for those, this might be familiar to most people, but for those who do not, who are not so familiar with meta-analytic approach, it is essentially a way of pulling the data from multiple different studies in a quantitative way. And what they did was they pulled data from 41 studies comparing patients with schizophrenia versus healthy controls. And as you can see in the list here, that these studies used a range of cognitive activation tasks, from NBAC task, delayed match to sample, a range of tasks. So it was not just one task, it was not homogeneous in terms of the tasks that were employed in these studies. So fairly heterogeneous. And this is really important because each task might then be engaging a range of cognitive processes, not just one particular cognitive process. And some tasks will engage certain cognitive processes more than others. And what they wanted to do was that, okay, irrespective of the fact that the tasks are different, there are some unifying cognitive processes that are engaged by all of these tasks. And these they call as general purpose cognitive control or conflict processing in the brain. And so they wanted to see, is there dysfunction in such a general purpose cognitive control or conflict processing network in people with schizophrenia? And the analytic approach that they used is a combination of two different approaches. So they used an activation likelihood estimate approach. Without going in too much into the stats of that, this is essentially, you can think of it that, let's imagine that the brain is made up of 10,000 volumes of a certain size, and they tested what is the likelihood of greater or lesser activation in patients with schizophrenia in any one of those volumes compared to patients, compared to healthy controls across these studies. And then they did some statistical thresholding to generate a map of differences. And that's one way they did the analysis. And then they did something different, the fractional similarity network analysis, which I'll come to in a moment. And what did they find? And again, the results here are not so important, though the key bits of results I'm going to kind of dwell on a little bit. And this is quite a busy slide. So here, the question they were trying to answer is that where in the brain are there activation differences between people with schizophrenia and healthy controls? Where do they converge across different studies? And in the top panel, they show results from controls, healthy controls, then from patients, and the bottom panel in the brain panel shows the results of the differences between patients and controls. And I don't expect you to be able to see all of that on your screen, but I have just summarized here that there are regions where, and these are listed here, bilateral, dorsolateral and ventrolateral prefrontal cortex, medial frontal gyrus, anterior cingulate, etc., where across all these tasks, schizophrenia patients in general had lower activation compared to healthy controls. And then there are some other regions listed in the bottom here, where schizophrenia patients had greater activation on average across these tasks compared to healthy controls. And so, although they pulled data from a range of studies, it showed that there are some consistent patterns of differences across all these different studies using all these different cognitive activation tasks, which have a common thread. The common thread being they all engage a particular cognitive process that they were interested in and that we know is affected in schizophrenia. So that's one way of analyzing. So they used activation likelihood estimate to analyze that. The second way that they analyzed is that which changes were co-occurring more often. And this is where they use the fractional network similarity approach, and where they found, again, some regions that were more affected together as opposed to more affected together in patients than in controls, both overactivated together and underactivated together in patients compared to controls. Their inference was that this will help them identify networks because they are going in the same direction across studies, across different cognitive tasks. These are networks that networks that work together. These are brain regions that work together in a similar manner, subserving those cognitive processes. And so essentially they found that there was alteration in function of the lateral prefrontal cortex. And what does it mean? The lateral prefrontal cortex, we know, is involved in top-down control to optimize cognitive processing across the brain to support task-appropriate response. We also know that the anterior cingulate cortex, which they found was differentially activated in patients and compared to controls, is involved in performance monitoring of conflict during information processing, dynamic modulation of the engagement of the dorsolateral prefrontal cortex during tasks. So it has a number of different roles. And all of this suggests that reduced activity in the frontal, subcortical, posterior regions perhaps is consistent with the idea that there is disrupted frontal top-down control function in people with schizophrenia. And greater activity, what about the greater activity in certain regions? Does it mean that they are compensatory responses? Does it mean that people with schizophrenia use alternative strategies to perform those tasks? So whether there are alternative strategies to in terms of allocating attentional resources, alternative strategies, alternative mnemonic strategies, or alternative strategies to monitor their own performance as they are doing the tasks in real time. Are they engaging those processes? And does that explain the greater activity in certain regions that we see? So I don't have an answer to these questions, but I want you to think about the results of this study using this framework. And I think that's quite a useful framework to try to understand what goes on in the brains of people with schizophrenia. That explains some of the behaviors that we see in them. Now, that's one example. Moving on to example 2. And of course, this is my own work, so it's easier to talk about. Venkat referred earlier to the cannabidiol work. And so this is one of the studies that we did with cannabidiol. It was a study where we investigated the effect of cannabidiol in people with at clinical high risk for psychosis. So these are people who experience, who do not have a frank schizophrenia diagnosis, but they experience similar kind of psychotic symptoms as people with schizophrenia, though they are less frequent and less intense, less severe than those experienced by people with frank schizophrenia. And these individuals have a very high risk of transition to frank schizophrenia. So, and at this point of time, there are no good treatments because we don't know for a given individual whether somebody will make a transition to schizophrenia or not. There are reservations around treating people with antipsychotic medications, etc. So, so we treated a group of such people with cannabidiol using a placebo-controlled randomized trial design. And so during the study, over the course of the study, there were clinical assessments that we did with our participants. There were dispensed study drug. We took multiple blood samples, and we also used neuroimaging to try to understand what was going on in the brain. And this is a schematic of the first day that they, once they entered the study. So at baseline day 1, so following randomization to either the cannabidiol treatment arm or the placebo treatment arm, we gave them the tablet to take. Before that, we did a clinical assessment, gave them the tablet to take, took some blood samples, and then about 2 hours after them taking the tablets, we took some more blood samples. Then they went inside the scanner, and we scanned them for about an hour. And after they came out of the scanner, we took some more blood samples. And although I'm not going to talk about the results of day 21, there was a similar pattern of assessments that we carried out in day 21. I'm going to focus only on day 1, what happened, and show you some results. And so this is just a plot to show that in the people who received treatment as part of this trial, this was the level of cannabidiol in their blood plasma. So as you can see in the CBD treated arm shown by the hashed line, there was increase in the CBD levels over time, and such an increase was not observed in the placebo treated arm as expected. And between this 2-hour post administration and kind of 5-hour post administration time point, we scanned them. And inside the scanner, oops, our participants performed a cognitive task, which was essentially associative learning task, verbal paired associate memory task. The task had multiple conditions, and during the encoding condition, we showed them words like these on the screen, word pairs, and we asked them, do these words seem to go well together? During a subsequent recall condition, we asked them which word was associated with it, and they had to say the word out aloud. And during a baseline condition, we showed them similar kind of background as in the previous 2 conditions, so the blue rectangles, but they didn't have to do anything. And all of these conditions were repeated multiple times to allow us to get a sense of what happened over repeated presentation. But I'm not going to talk really about what happens in terms of learning, but across encoding conditions or across recall conditions, what did we see in the brain? Aside from those who took part in the trial, we also studied a healthy control group who underwent the same kind of scanning, but didn't take part in the trial, didn't receive any drug treatment. That was to help us contextualize what we would be seeing in the trial participants, to know what was the normal condition by looking at the control group, and then compare what was going on in the placebo-treated patients who received a single dose and the CBD-treated patients who received a single dose. So as you can see here in the top panel, the red and yellow clusters show bilateral striatal activation. And in the healthy control group, this region was more engaged. And in the placebo-treated group, who received a single dose, this region was less engaged. And the engagement was intermediate in the CBD-treated group who received a single dose of CBD. It was not just in the bilateral striatal areas, but if you look at the bottom panel as shown here, there was also difference in a large cluster, starting from the parahippocampal gyrus, extending to the midbrain and also into the cerebellum, where again a similar pattern of effects was evident, suggesting that this brain regions were more engaged in the healthy controls, less in the placebo-treated patients, and intermediate in the CBD-treated patients. So this was really to get a sense of our objective was to use neuroimaging to try to understand, does a single dose of CBD engage with or target the brain regions that we think are abnormal in people with clinical high risk of psychosis. And current understanding of what leads to psychosis is one of the theories, and this is not the only theory or the most important theory, but this is one of the theories, is that genetic and environmental insults lead to GABAergic neuron interneuron dysfunction, and that in the pyramidal cortex, and that leads to downstream effects in terms of enhanced glutamatergic tone in the hippocampus and medial temporal cortex, that leads to increased activity in the striatum and increased midbrain dopamine neuronal activity. So this is where we see the increased striatal and midbrain dopamine levels in people with psychosis, as well as in people who develop, who are at clinical high risk of psychosis. And the understanding is that this increased activity in the dopaminergic regions of the brain leads to attenuated psychosis symptoms. So what did our study show about what does CBD do? It shows that CBD perhaps has an effect in terms of attenuating some of the glutamatergic tone. Of course, we didn't measure glutamatergic tone. We are inferring on the basis of certain changes that we are seeing in brain function. And perhaps also, similarly, it affected striatal and midbrain activation, indicating that perhaps it has an attenuating effect on the increased activity or increased dopamine function in striatum and midbrain. Of course, we didn't measure those, but this is an inference that we can draw based on what we saw. So this is one example. I thought it will be useful to think of another example, but I can see that the clock is ticking and I have not been very kind of moving very slowly. So perhaps I think I will skip so that kind of we can move to some questions as well. Now, I've shown you essentially two examples. So it's useful to think about the limitations of some of these approaches, that all of these depend on what is known as forward inference. And this is all summarized in a couple of reviews by Russ Poldrack, and I have included those here. So this is just a summary. And again, this is useful to conceptualize and to get a better sense of the limitations of the different techniques that we use. The results look very fascinating, but we need to take those results with a pinch of salt. So for example, if we see difference in the engagement of brain regions when we compare two conditions that differ in some putative mental processes, then we may infer that those brain regions are involved in that mental process. But of course, what we use is a correlational approach, that two things are happening at the same time. Hence, we cannot be certain that the region that we see is differentially activated is either necessary or sufficient. And Russ Poldrack talks about how hippocampal involvement often comes up in studies of classical conditioning, particularly fear conditioning. But of course, if there is a hippocampal lesion, that doesn't necessarily result in that doesn't affect classical conditioning or fear conditioning, suggesting that hippocampal involvement is neither necessary nor sufficient. So we might see something within neuroimaging, but we need to kind of better understand whether those changes that we see are either necessary or sufficient. Of course, how do we address that? We could address that by manipulating those brain regions using other techniques to get a better sense of whether it's a sufficient or necessary alteration. And of course, the important thing to note is that there are no lesions in psychiatric disorders such as psychosis. So we need to understand all of this, take all of this with a pinch of salt when we interpret the results. And the other important thing to note is that the brain may have multiple ways to perform a task, multiple new degenerate neural systems that may sustain the same cognitive function. And this is where I take you back to the first study that I showed you, the example that I showed you, the meta-analysis. They used the combined data from a range of tasks. And across those tasks, across those studies, they found some common abnormal areas of abnormal activation, suggesting that each of these different tasks engage some common processes, some distinct processes, of course, but some common processes. That really speaks to this multiple degenerate neural systems that we have. Otherwise, kind of humans would not have survived for so long unless there were degeneracies built in. The other thing to think about is that we have till date now mostly focused on modular approach to structure function relationships. However, many cognitive processes may be distinguished not by activity in specific brain regions, but by patterns of activity across many brain regions. If you go back to the first example, the second slide that I showed in relation to that, I showed where all changes co-occur. So it is not about changes that occur in different modules, but changes that occur across regions. So we need to think about that as well. We can't just think of it in a modular way. This is really to advise caution and not to regard all such evidence as useless. And can we use then, therefore, neuroimaging to inform mental processes in different psychiatric disorders? Of course, that takes into account, kind of leads us to the question of logical fallacy. Say, for example, right now, the gods of internet forbid that I suddenly have a disconnection of my internet. My internet plays up here, and you stop seeing or hearing my talk. Now, so then if that happens, you might infer that there was a problem with the internet. But of course, something else might also cause the same thing. My computer may not be linked with the power source, and the battery might die down, and that might cause the same effect, that there is a disconnection, you don't hear or see me any longer. So suggesting that just because you stop seeing me, the fact that this was caused by an internet problem is not the only cause for that. There could be many other causes that might lead to the same effect or the same consequent here in this context. So when we are inferring from the results of our neuroimaging studies, we need to be mindful of this fallacy. If and only if the specific cognitive function affects a certain brain region of interest, then it might be true. And so in the interest of time, I won't be able to go into this, but I think I urge you to all have a look at this great study from nearly 2 decades ago, where they showed exactly this, that there are lots of degeneracies. There are lots of different brain regions that serve similar functions. There are lots of different functions that are served by different brain regions. So it's really useful example of what Russ Poldrack was talking about in the context of fMRI. So brain regions activated by fMRI are seldom activated by only one cognitive process. So we need to be mindful of these. And then, of course, there are other limitations. It was not designed with clinical utility in mind. We focus too much on structure function associations rather than, is the effect large enough to have clinical utility? And we spoke about the voxels, about the many tests that we do in mass univariate approaches. But just remember that it's worth reminding us that each voxel might, a 1 millimeter cube voxel will have around 5.5 million neurons. They might have diverse properties, functions. So we are measuring one signal in one voxel. That is the readout from 5.5 million neurons. So there is a lot of functional, a loss of functional specificity or inference from such approaches. They generate population level inferences. They typically combine groups of patients and controls and contrast them to identify general patterns of brain activity that differ between groups. So such approaches generally ignore heterogeneity or between individual differences, or patterns consistent across individuals. So these are some of the limitations that we need to think about. And I'll skip some of the more slides. So to move on to finally the future directions. I think there are lots of changes happening. People are moving to more from modular to more connectomic approaches, from mass univariate analysis to multivariate pattern analysis approaches, from prediction about populations to more individual level predictions, from structure function relationships to focusing more on clinical utility. So changes are underway, and I'll stop there. So the future is not as bleak. So these are my funders. So and thank you very much for listening to me today. I thought that I'll just try to articulate some of my thoughts, perhaps not so in a not so articulate way, but I'll stop there.
Thank you. Thank you, Dr. Sagnik. That was wonderful and comprehensive, and I would say a very lucid illustration, starting from the fundamentals of brain imaging and its implication, especially in the context of understanding psychosis through the window of cognition, as you nicely emphasized, and then the exemplar applications that you presented are quite insightful. And then, of course, contextualizing it in the within the limits of it is something very, very important. So it has been a great learning resource. So thanks a lot. And I think I'm just going through the chat box to see if there are any questions. I think as people type in their question, maybe I thought I'll chip in with a couple of thoughts I had in terms of questions. So one of the example that you presented, which is the meta-analysis from the JAMA Psychiatry. So it talked about the cognitive control and the conflict processing circuits. So I'm curious to understand because some of these cognitive deficits are also implicated in, say, disorders like obsessive compulsive disorder, in which you have done some very pioneering work. So I just want to understand how can we make sense, if at all it is possible, to understand the differential symptom correlates, if at all there is some work in this area. So
yes, I think you have asked a very important question, and I'm not sure I really can give a good answer that addresses that question, but I'll still try to kind of articulate my own thoughts in this regard. So, of course, there are different ways to try to relate the cognitive process alterations to the specific presentations in the distinct presentations in the two disorders. In obsessive compulsive disorder, you have a certain kind of presentation, while in psychosis, you have completely different presentation. So how do we reconcile the fact that there is a similar network that is dysfunctional in both these disorders? Now, this just really, to my mind, highlights the challenges of trying to understand complex mental phenomena. We try to simplify some of our understanding about mental phenomena by categorizing different mental processes, say, for example, cognitive control, etc. But of course, when somebody is psychotic and experiencing hallucinations or has a delusional belief, it's not just cognitive control alone that is at play that might explain the delusional belief, or kind of means it very likely doesn't explain any of that at all. It just perhaps indicates the other behaviors that we see in people with psychosis that really reflect discontrol over thoughts and behavior, and that's what we see here. While the cognitive control in alteration in people with OCD might be in a completely kind of at an other end one could potentially think of. And again, I need to be very careful because I'm in the presence of stalwarts of obsessive compulsive disorder research, and kind of I don't have much experience. Is that do people with OCD have hyper control? So although we see certain changes in similar networks in both patients with psychosis and in OCD, actually the control alterations are different. One might be less control and another might be more control in OCD. And as a result, the behavioral manifestations are different. But also, as I said earlier, that it is perhaps a bit too simplistic to try to explain a complex behavior in terms of one single mental process. As of now, right now, when I'm listening to you, or you are listening to me, you are looking at me, you are hearing me, you are also seeing my movements, my gestures. So there are lots of cognitive processes that are underway. You're thinking as I'm speaking, you're trying to understand. So of course, we can't systematically measure all of these at the same time. That's why to simplify, to help us understand things better, we simplify, we focus on cognitive processes that we can reliably, demonstrably, and multiple kind of times in the same way we can measure and we can engage. And that's what we do. But then they don't capture the complex reality of symptoms.
Yeah. I think thank you. Thank you for emphasizing that we can make things simple but not simpler. Yeah, if I may surmise. Actually, taking on from the multi-sensory integration that is happening, I think there's a question related to that. Does disturbance in multi-sensory integration play a role in pathophysiology of psychosis? And can imaging techniques help us understand these mechanisms?
Tough one. Thank you for asking that, but it's really a tough one. And of course, I think this is a really important one. Means in general, when we think of somebody with psychosis, so one way of thinking about the experiences that they have is to think about a disintegration of connections between things. So in the using the general approaches that I have given an example of, where we look at brain regions as modules, we look at whether some brain region is more activated, less activated, and we then threshold them. Then we identify a range of brain regions which are more activated or less activated in a group of patients versus a group of controls. And sometimes in the course of that, we will identify brain regions that are involved in multisensory integration. So integration of information from multiple modalities, and they keep coming up all the time, in particularly in meta-analytic approaches, in the Minzenberg study, but also in some of the other studies that we have done, not in patients, where we have used similar kind of strategies in terms of combining data from multiple different cognitive tasks. In particular, one of the things that I remember is that we tried to investigate in people with cannabis use, what are the core brain abnormalities that are common to all studies in people with cannabis use. And we combined data from studies that used different cognitive tasks. So there were some verbal memory tasks, there were some tasks that looked at fear processing, there were tasks that involved reward processing, etc. But across all that, we found brain regions that are involved in integrating information from multiple modalities are coming up as abnormal. So that's perhaps and I'm giving that example in the sense that at least ecologically, we know that there is a great deal of some validity to the fact that cannabis use is a risk factor for psychosis. So in some ways, what we see in cannabis users is like a snapshot of what might happen at a much grander, greater scale in people who go on to develop psychosis. Not the same thing, but maybe earlier part of the process. And so, and the fact that there also we see some alteration in the function of these regions which are involved in integrating information from multiple sensory modalities, that's really reassuring. And that's perhaps a core thing. But I wonder whether our current analytic strategies are enough to find evidence of this. Perhaps we should really look at more connectivity analysis, functional connectivity analysis to have a better sense of this.
Yeah. Thank you. I think that has clarified this particular question. And I'll just go to a couple of last questions that we will take, especially I know that you have to go for your lunch. So there are two questions. That is, one is it possible to build a precise prediction model based on neuroimaging data to diagnose psychiatric conditions like psychosis? And the related question is, how can we see a role for bioinformatics in such a kind of approach? That is, one is the prediction model, and is there a role for bioinformatics?
So kind of let me clarify a little bit. So is this the first question, part of the question, referring to prediction error learning and that kind of aspect, or
I think
or more of prediction as in prediction of outcome, prediction of
prediction of psychosis as an outcome?
Yeah. Okay. Prediction of diagnostic prediction and all of that. Yes, means I think these are being applied all the time with increasingly larger data sets. Of course, the interest is in can we predict on the basis of a simple scan who has psychosis or not? So that just like we have an MRI scan to diagnose, to tell us where the stroke is, can we just on the basis of an MRI scan say that somebody has psychosis and not have to do 1 hour or 1.5 hour diagnostic interview and then even then being unsure? I think those approaches are being used, and the hope and for those who use those approaches, I haven't myself used those approaches, though I can see an inherent attraction of those approaches. There is a usefulness of those approaches. Whether they will stand the test of time to be able to reliably and being both sensitive as well as being specific. So not just differentiate those who are patients from those who are non-patients, but differentiate between different patient diagnosis categories. I don't know. Means the hope is that yes, they should be able to at some point of time. But I think this is quite a complex one. Means at least in the more shorter term, I see a combination of approaches. So, for example, where it's not just scanning on alone, which predicts whether somebody has a diagnosis or not, or what might be the outcome, but say, for example, scanning data plus also clinical data, other measures, because the things that we are trying to predict are fairly complex. When we try to simplify, we have to simplify to better understand what's going on, to disentangle the different processes. But simplification of a very complex thing is challenging. And so I'm not sure. I don't have a good answer that, but I can see the attraction of these approaches: prediction, outcome, prediction of diagnosis. They are definitely very, very attractive approaches. They will have a lot of clinical utility. So I hope it works.
Okay, okay. Thank you. Thank you, Dr. Sagnik. So the last question that we will have is, during your presentation, I think this is the question which has been posed by one of the participant, that you mentioned that there is no linear and one-to-one pattern from the tasks and experimental manipulation to cognitive function. Hence, so are there any specific parameters inculcated in the experiment while inferring results, especially when there are multiple tasks directing to us the same cognitive function?
Yeah, I think yes. So means if there is one thing that I want people to remember at the end of this talk, it is that this is complex, and there are no easy answers. There are no easy ways. So you have to take it all in, all the results together. So one is that's why it is so critical in the context of neuroimaging studies, which involve cognitive activation, that we measure task performance. We measure task performance as much as possible, and then we try to use the information regarding the task performance, the differences, evidence from other studies, to try to infer what is going on. And sometimes we can make reasonable guesses, but just like the internet causing disconnection and stopping my talk, and similarly the my power failure causing dysfunction and stopping my talk, we need to think about what is a more likely. We have to weigh the pros and weigh up the possibilities and try to use all the other information that we have from task performance, from what we know from neuroimaging literature in healthy people, how it works. Are those brain regions necessary and sufficient for that particular cognitive process? So we have to use all that information to try to interpret. And we need to be also mindful that some of those interpretations may not be, the real truth, the absolute truth. Our kind of understanding will evolve over time. So yes, means I can't give you real closure in that regard. It is difficult. These are difficult things. So we just have to be mindful of the limitations.
Yeah. Thank you. Thank you for emphasizing it, especially making us understand the complexity of these interactions. Before we conclude, maybe I'll request Professor Reddy, sir. Sir, if you have any concluding remarks, perhaps we will take your remarks and then I'll hand over the session to Anushka. Anushka?
Okay,
Yeah.
thank you.
Yes.
Thank you, Sagnik, for that wonderful presentation. And I was reminded of Sagnik of those days, the answers that he gave to various kind of questions. He's never dogmatic about what he has done, and he's able to see, the different aspects of the findings and not just persist with, I found this and this is the answer for everything. That's the kind of, sometimes we get carried away by this. But it was a fantastic presentation. I loved listening to him. I hope we'll be able to host him more frequently. Thank you, Sagnik, for making time and talking to all of us. Thank you.
Many thanks, sir, and kind of the organizers, Venkat. It's really real honor to talk to you, all of you.
Yeah, thanks, Dr. Sagnik. I think it has been a great learning experience, and we will follow the leads that you have directed to, understand more about some of the complex issues which you have elegantly summarized. So now I'll hand over the session to Anushka. Yes, Anushka.
Thank you, sir. For that was a very insightful talk. Thank you for making the time for us today. I think there's a lot of people who really enjoyed the session. They're leaving their comments. So we'll just wrap up for today. Thank you everyone for attending this webinar. We will have more webinars in the future. So if you're not already subscribed to our mailing list, please do. I've shared the link in the chat box. You can follow us on our social media channels. You can subscribe to our mailing list. And this video will also be available on YouTube for public viewing. So you can check it out there if you would like to share it. Stay tuned and thanks again for joining us. Thank you, everyone.
Thank you all for the invite. It's a pleasure. Bye. Bye, sir.